Good afternoon, everybody. Welcome to the Surescripts booth. We have a great discussion today about a problem that's affecting our nation, opioid abuse. There's been a lot of the national dialogue the past few years at the federal and state level about this problem. And what we're here today to talk about is how health information technology and actionable intelligence that can be delivered through that technology can be brought to bear to solve this problem.
Drug overdoses kill more people in this country right now than car accidents, about 47,000 compared to 32,000. We are not safer drivers. I'm here to tell you from driving on Route 128 in Boston that we are all miserably terrible drivers, but technology and safety standards are saving our lives on a daily basis when we're driving. We need to make sure that we do the same thing with regard to narcotic prescriptions and other controlled substances.
Abuse deterrent formulations are great to stop people abusing drugs on the street, but it doesn't matter in the clinic. If you chronically treat that patient with an abuse deterrent formulation or any formulation, once you stop that drug, they're going to go into withdrawal. And there's only one surefire way of eliminating withdrawal. Take a drug, whether that be a prescription drug or an illicit drug.
I remember when OxyContin first came out, the big marketing push was actually less of a potential for abuse because it was a long-term, long-acting drug. It was encapsulated so that it would be a long, slow release. The first street addict that got a hold of it took it and put it down and went bang, 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 bang.
Yep.
That's awesome. And so completely defeated millions of dollars of market research by smashing it up and snorting it and then potentially taking it in a way that it wasn't necessarily designed for.
About 80% of the controlled substances at Michigan are written using an EPCS system with all those steps defined by the DEA, where it's required to match up the physician or the provider with the token, with the identification factor that they're using. So I think that we're very tight that way. Certainly we continue, as most people do, to optimize and tweak our electronic record, and that includes some of the workflows inherent with e-prescribing of controlled substances.
Along those lines, how do you initiate and maintain and actually implement EPCS, or electronic prescription of controlled substances, and how to use intelligence to actually curb this opiate abuse and narcotic abuse epidemic using things like prescription monitoring programs or Surescripts systems where you can actually do med reconciliation and find out what somebody's been taking and when and where?
The law was adopted many years ago. When we look at, though, enablement, right, pharmacies, over 90% of pharmacies are ready to accept this. If you look at the provider community, only about 14.5% of providers are really enabled to prescribe a controlled substance electronically. What are some of the barriers that you think account for that?
There is part of the requirement that when a physician or provider is going to do that prescription, they go out and take a look at both the patient history, and most states now have a system that they're collecting that history. In Michigan, it's called MAPS. And the regulation actually says that the physician prescriber is required to go out and check that. But we actually do not have a forcing function to force the physician, provider, prescriber to go look at that works.
If it's a manual token where you have an app on your phone where you have to break your concentration while you're caring for the patient, take your phone out, sign into your phone, sign into the app, look for the app, find the 6-digit number, go back to the keyboard, type it in. If you didn't get there fast enough in the 30 or 60 seconds, it regenerates another one-time PIN. You got to do it again. Sounds like not a big deal, but breaking a clinician's workflow over and over again for that can be difficult. So you can see how, depending on whether the technology's good or not, it can be a separator how usable it is. Knowing what medicines a patient takes is priceless. Getting that information in real time makes an incredible difference in a patient's care.
People are still going to get abuse heroin. We're still going to need to prescribe methadone and buprenorphine. So it's never going away. We're definitely going to have to keep prescribing those drugs. So this whole conversation about what Surescripts can bring and the electronic medical records is not going away, and we just need to ensure the workflow grows quicker.